So what is the take-home message for today's presentation? Artificial intelligence can help to automatically extract important insights from nursing data to improve patient outcomes. And I'm going to give you some concrete examples of how this is done. So in terms of talk outline, I will briefly present my personal bio. Then we will move to talk about two specific technologies that belong to the large group of artificial intelligence solutions in healthcare and nursing. Specifically, we will talk about natural language processing and clinical decision support. We will then summarize the presentation with some takeaway points. So this is the place where I was born. It's a beautiful place in Siberia, Russia. However, my hometown looked something like that. So small industrial town in the middle of Ural Mountains. This is my first computer. So that's how I developed my passion for informatics, for information technology. So I had to hook it up, this metal box, to the tape and to the TV to be able to upload the software and play a Soviet version of the Mario game. So it wasn't as exciting, but I definitely learned a lot, and it kept my passion for information technology alive until today. This is the place where I spent part of my life. It is in Israel, so I immigrated to Israel. And in Israel, I was a combat medic in the Israeli army. That's where I started seeing some of the healthcare sides of artificial intelligence. Specifically, I was fortunate to be implementing some of the first electronic health records in the Israeli army. So that experience gave me a lot of food for thought how information technology can help nurses and other healthcare providers doing their job better. This is the beautiful place, the University of Haifa, where I completed my master's and bachelor's degrees in nursing. And I worked in this beautiful hospital, Rambam Hospital, in inpatient medical surgical ward as a nurse. I then went to the United States, to a city called Philadelphia, where I went to the University of Pennsylvania, where I was a Fulbright fellow, and I was fortunate to learn a lot about clinical informatics, about nursing informatics in this place. So that's where my PhD is from. I then went to Harvard Medical School and Brigham's Women's Health Hospital in Boston. That's where I got my postdoctoral training, and I learned a lot about natural language processing, so another aspect of informatics. I then came back to Israel for a few years, where I started health informatics lab at the University of Haifa. And most recently, I moved to Columbia University in New York. So I'm partly affiliated with School of Nursing and Data Science Institute. And I also am affiliated with a very large home care organization that provides services for the whole area of New York. So we have about 44,000 patients on the daily census. This is the largest non-for-profit home care organization in the United States. It's called Visit and Nurse Services of New York. So that's where I am at now. So this is my motto: nursing data for good. So what data is available in healthcare? We have these data sources are growing rapidly. And we have sources like emails, patient records, conversations on social media, and many other places where patient information is recorded, and we can potentially make use of all of this information to make better decisions about our patients and achieve better health outcomes. With that, about 80% of all health data is captured in the narrative format. So some of the examples of those narrative formats are nursing and physician clinical notes, for example, admission, assessment, follow-up, comments, discharge summaries, radiology notes, etc. There is a communication that's going on between clinicians, which include emails, text messages, administrative, different administrative communication routes, and so on. And there is also a scientific literature where you can find a lot of useful information, which is, you know, that articles today grow exponentially in their number. So in terms of the personal experience, I was writing a lot of clinical notes when I was working as a nurse, and I would write notes like patient with no diagnosis of depression. Patient is taking antidepressants regularly. Patient had depression. She has major depressive disorder, right? That's an abbreviation. So these are some of the things that I was documenting. So one technique that belongs to a larger group of artificial intelligence technologies called natural language processing can help make sense of this unstructured data. So natural language processing is about a combination of computer science, artificial intelligence, and computational linguistics concerned with interactions between computers and human natural languages. When you add health to the mix, you get health NLP, health natural language processing. So basically, as you can see in the picture, the goal of natural language processing is to teach computers to understand clinician or patient recorded information. So I wanted to give you a very brief insight into how natural language processing works. And basically, there are two types of methods that you can use for natural language processing. Number one is rule-based methods. So in rule-based methods, we basically create a set of rules for the computer to be able to process millions of clinical notes. So let's look at an example. So example of nursing note would say something like that. Patient has MDD. MDD is an abbreviation that stands for major depressive disorder. If we want the computer to find it, we need to tell it that MDD is an abbreviation, create some type of vocabulary, and then computer will be able to search for those terms independently. With that, sometimes those concepts would be negated. So in this example, we see that patient doesn't have MDD, right? So at the very least, computers need to be able to figure out when they read the clinical note, they need to be able to figure out that patient doesn't have MDD, doesn't have is a negation that stands just before MDD, which means that this patient doesn't have major depressive disorder. So computers need to be able to think about those things, and we teach them how to do that. So in natural language processing that is rule-based, we basically write rules for the computer how to process large samples of clinical notes. The algorithms can go something like that. So step number one, read nursing note, right? So read, we give a computerized format nursing notes to the computer. We ask it to find words and expressions describing presence of depression. We then making sure that words and expressions are not denied, so there is no negation before the words. And then we repeat numbers 1 to 3 for each nursing note. And at the end, we will get a final description of how many patients in the sample had a documentation of major depressive disorder. Approach number 2 is machine learning-based natural language processing. Basically, we ask computers to find patterns in the data. So in the example, you can see several expressions that describe patients having major depressive disorder. So for example, a clinical note would say patient has MDD or suffers from depression. We need to define for the computer that those notes basically they describe presence of clinical depression. Whereas other notes like complaints on headache and presents with fatigue and nausea, those clinical notes, right, those snippets of text do not have major depressive disorder documented. So in the machine learning approach, we are asking computers to use statistical techniques to find which text patterns are associated with having a depression. So in our example, a computer should be able to figure out independently that MDD is something that defines depression, that the word depression is something that defines depression. So that's what we do in machine learning approaches. And in terms of the number of approaches that we can take to implement those machine learning methods, there are a variety of approaches broadly that can broadly be classified into classification, regression, clustering. So you've heard about some of those. And this is just a tip of the iceberg of some of the methods that we can use for machines to learn independently. So in terms of the result, right, basically what we want to have as a result of machine learning, natural language processing, we want to be able to give computers a set of sentences, a set of clinical notes, for example, and we want to ask it questions like, do patients have depression? And computers should be able to figure those out automatically. So that was just a very brief preview of some of the distinctions between rule-based and machine learning natural language processing methods. Now let's look at some concrete examples, right? So really, what do we do with this natural language processing? So first example is about ineffective, we'll show you that ineffective self-management is associated with rehospitalizations among heart failure patients. So in this study, we know that effective self-management can decrease up to 50% of heart failure hospitalizations. Unfortunately, self-management by patients with heart failure remains poor. So in this study, we wanted to build a rule-based machine natural language processing pipeline that would identify ineffective self-management documented by clinicians in the clinical notes of patients. And this is how it would work, right? So imagine in the box B that you see on the screen, you have patient note, basically discharge summary. So patient has not been fully compliant with her medication regime. We want the computer to be able to understand that these words that are presented in the clinical note describe poor medication adherence. We also want the computer to be able to understand that failed to attend appointments describes missed medical encounters. So that's what the algorithm that we created basically in this study. The algorithm was able to pretty accurately understand and extract those features from text. So our algorithm achieved relatively high accuracy. And how do we know what's accurate? How do we know if our natural language processing algorithms are accurate or not? We usually have expert clinicians that manually review, right, that read clinical notes. And then we want the computer to match them, to try to basically do as well as humans do when they read clinical notes, right? So the question that we are asking nurses in this case is whether there is documentation of poor self-care management in the clinical notes. And then we are asking the computer to repeat the same procedure to understand whether there is documentation of ineffective heart failure self-management in those clinical notes. And we want the computer to be able to match the human. So that's how we measure accuracy. In terms of the results for this study, we found a documentation in a relatively large sample of patients, about 9,000 patients, with about 35,000 discharge notes, right? So we couldn't read this manually, so we couldn't do it by hand. So we applied this natural language processing. We identified that about 15% of patients had documentation of ineffective heart failure self-management. We then conducted logistic regression. So basically analyzed whether documentation of ineffective heart failure self-management is associated with higher risk for admission. And we did find associations, which is not surprising to the clinicians, but it just shows you the power of the natural language processing, of what things we can find in the text and what kinds of studies we can do with it. In the next examples, we use natural language processing to predict patient hospitalization and emergency department visit using clinical notes. So a specific setting, just in terms of background, we know that about 30% of patients are hospitalized or visit ED during home care. Home care is when nurses come and visit patients in home. Nursing data can help to identify hospital patients at risk for poor outcomes up to 26 hours prior to the event. So we know that from some other studies. In this study, the question was, can we use nursing notes to predict which patients are going to be hospitalized or visit ED? So in terms of methods, we had a relatively large database of clinical notes, so about 700,000 clinical notes, written for about 110,000 patients that were seen within a large home care organization. The outcome of the study was hospitalization or ED visit. And then we applied several machine learning algorithms to try to predict which patients are high risk for hospitalization just using the notes written by nurses. So what we found is that actually we can identify patients who are at risk for emergency department visits and rehospitalizations from home care using machine learning. So the best machine learning algorithm, random forest, achieve and recall and precision, you can see on the screen, so accuracy of about 0.80%. So about 80% accuracy in predicting which patients are going to the hospital or ED, or will visit an ED. And here are some of the categories of words and expressions that emerged as predictors of patients' hospitalization. So in terms of categories, we had clinical factors, things like describing patient symptoms, for example, dehydrated or vomited or nauseated, right? We had instance of coordination and communication. We had indications of service use. So for example, skilled nursing or to ER, to emergency department. We have indications of social and environmental factors. So patient live alone, income being mentioned, right? It's probably poor income being mentioned or low income being mentioned. We had some temporal and other types of factors that were associated with high risk for hospitalization. So in terms of the discussion for this, home care nodes are highly informative to identification of patients at risk. You can imagine a system that will proactively identify patients at risk and alert nurses on concerning trends based on this work. And here you can see a citation at the bottom of the slide for this article. So example number 4, automated speech recognition can help assess shared decision-making and predict medication adherence from audio recording of primary care encounter. So this study was about something slightly different. In terms of background, we know that asthma is a common chronic illness. It is affecting about 19 million patients in the US. We know that there are good treatments for asthma. So inhaled corticosteroids adherence among patients with asthma would lead to better outcomes. However, adherence to those treatments, right? So how often patients do take those treatments, this adherence remains poor. We know that shared decision-making, a patient activation strategy, can improve patient adherence with medications. So we know that better communication between providers, healthcare providers and patients can improve patient adherence. In this study, what we did, we recorded 80 encounters. So we audio recorded 80 encounters between nurse practitioners or primary care providers, so physicians, and patients, and those encounters were about asthma treatments. So our goal in this study was to explore whether audio-recorded patient, primary care provider, and nurse practitioner encounters can be used to evaluate the level of shared decision-making and predict levels of patient medication adherence. In terms of methods, we have several standardized tools that assess shared decision-making and patient medication adherence that are presented here on the slide. In terms of taking the speech and converting it into the text, we use speech-to-text algorithms. These were used to automatically transcribe 80 audio-recorded encounters. And we use several machine learning to create predictive models. In terms of results, so first of all, we use the commercially available package for speech recognition to be able to transcribe speech to text. It was an Amazon product. The accuracy of automated speech to text transcription was relatively good, about 90% on one hand, right? On the other hand, it's not very high accuracy for clinical purposes. Imagine 1 in 9 words are misspelled or spelled wrong by the automated speech recognition. We then looked at we then created machine learning models that had a good predictive performance, and they were able to predict shared decision-making during the encounter with accuracy of about 88% and medication adherence, accuracy of about 87%. So here are some of the words that were associated with higher levels of shared decision making, right? So those words include different things that describe feelings, for example, right? So you feel that, feel that, feel that you. So when clinicians use this type of language, it is more likely that patients think that their level of shared decision making communication with the healthcare provider is higher, which is not surprising. So imagine a world with automated nursing care quality control and automated prediction of patient outcomes, right? So imagine if we record all the conversations that happen between nurses and healthcare providers, and then we can identify between nurses and patients, I'm sorry, and then we can identify concerning patient trends. We will be able to use this new automated approaches to improve health and basically identify patients at risk and improve patient outcomes this way. So to accomplish a lot of natural language processing tasks, we developed a software. The software is freely available. Anybody can download, and we have multiple downloads from many countries around the world. And we focus on English right now and Hebrew language. But however, we did Hebrew language as well. So this software basically can be downloaded and used for natural language processing. It's called Nimble Miner. Again, it's publicly available without any payment. Anybody in the world can download it and use it. And we use the software in several studies that I described. So some of the other projects with Nimble Miner, we used it to identify fall-related information in clinical notes. We have a study about identifying dementia symptoms, and we showed that documentation of dementia symptoms is associated with higher hospitalizations and emergency department visits among home care patients. In another study, we are looking at identifying all the symptoms for patients hospitalized in the hospitals. And we know that in nursing, symptoms are very important, right? So symptoms are one of the core things that we do as nurses, symptom assessment and management. And in this study, we're basically creating a very large pipeline for extracting symptoms from clinical notes. In a different study that's ongoing right now, we're working on identifying COVID-19 symptoms in emergency department clinical notes, which is another important project that helps us understand how frequently symptoms were reported and documented. All right, let's switch gears and talk about clinical decision support. So what is clinical decision support? Clinical decision support systems provide clinicians, staff, patients, or other individuals with knowledge and precision-specific information intelligently filtered or presented at appropriate times. And let me give you an example of what are some of the trends in nursing clinical decision support. So here we're looking at the results of a systematic review that was published in 2017. So it's a little bit dated, but there is no newer systematic review on clinical decision support in nursing. So this review basically included 28 articles that were doing work in developing or implementing clinical decision support. Among those studies that were included, most of those were quasi-experimental or descriptive. There was only one randomized control trial of the clinical decision support, which means basically that we don't have a lot of evidence about the effectiveness of clinical decision support. In terms of the purpose of decision support, so many of the decision support tools were supporting diagnostic decision making, so trying to help diagnose patients. Some decision support tools were geared towards improving guidelines adherence among nurses. Medication management was another frequent domain for decision support tools, and situational awareness. Published studies do not report negative effects of clinical decision support. Clinical decision support systems targeting bedside nurses had positive effect on outcomes and hold promise for improving care quality. However, as concluded with this systematic review, this research is lagging behind studies of clinical decision support targeting medical decision making, both volume and level of evidence. So there is a lot more that is known about the effectiveness of clinical decision support among physicians. And I wanted to give you a concrete example of our work on clinical decision support. So the first example here will be about patient prioritization at admission to home care. So just to give you a brief background, in the United States, there are about 12 million Americans that are admitted to home care agencies annually. About 30% of those patients are hospitalized. And about up to 60% of rehospitalizations happen within the first weeks of home care services, which means that early and targeted allocation of services can help reduce readmissions. However, it is unclear which patients are at the most risk for readmissions when they come into the home care. So we had a study that developed a clinical decision support tool called PREVENT. And this tool, so PREVENT is an abbreviation for Priority for Home Health Visit Tool. This was a predictive study of home health visit priority decisions made by nurses. Basically, this clinical decision support tool helped nurses decide whether a patient that is coming out of the hospital to home care should be seen for the first home care nursing visit today, tomorrow, or never. Never is not an option, right? But are there patients, this tool helps identify those high-risk patients that are coming out of the hospitals and would be likely readmitted. So basically the tool includes 5 factors. And those are factors that we discovered in the study that developed the tool. So those factors include wounds, comorbid condition of depression, limitation in current toileting status, higher number of medications, higher number of comorbid conditions. So each one of those factors contributes to patients' risk for rehospitalization from home care. And when we create those clinical decision support tools, each one of those factors receive a certain score. So you can imagine applying, basically calculating how many factors does each patient have and receiving some type of a score for a patient. Based on this score, we know whether a patient is a high priority for the first home care nursing visit or low, medium priority for the first home care nursing visit. So in terms of the pilot work for this project, we developed this clinical decision support tool, but then we wanted to see how effective it is. So we conducted pilot on improving patient prioritization during hospital to home care transition. We received funding from Eugene and Joseph Doyle Research Partnership Fund at the Center for Home Care Policy and Research, the Visiting Nurse Service of New York. The aim of this study was to test, prevent, and determine its effect on timing of the first nursing visit and patient 30 and 60-day rehospitalization rates. So this study included about 200 patients. We had a pre-experimental phase where we didn't tell nurses what patient priority is. And then we had the experimental phase where we did tell nurses what each patient priority is. And what we saw, basically, we saw that there was a decrease of about 35% of rehospitalizations between the pre and experimental phases in this study. So that's how we knew that there is a possibility that tools like that work, that this tool, PREVENT, can reduce rates of rehospitalizations by identifying patients who are failing, but identify patients who are sick early on. Right now, we have an ongoing study that is called Improving Patient Prioritization During Hospital to Home Care Transition. So a larger study of this same tool, PREVENT. So we received funding from the National Institute of Nursing Research in the United States to do the study. The objective of the study is to evaluate the efficacy of the PREVENT in a pre and post intervention study using rigorous, robust statistical methods. So in terms of the study workflow, I just wanted to give you a brief overview of what's going on in this study. So first aim of this study, in the pre-intervention phase of the study, again, we will automatically calculate the PREVENT score. So we will integrate the PREVENT score to be calculated automatically by the electronic health record systems, right? So nobody needs to calculate all of those factors for each patient. The electronic health record system will do it automatically. In the intervention phase of this study, we will share information about about patient priority for the first home care nursing visit with nurses, and we hope, and then in the post-intervention phase, we will evaluate the effects of the clinical decision support tool on patient outcomes and basically nursing workflow and nursing outcomes, right? So we will do different types of evaluation that include interviews with nurses, user satisfaction surveys, exploration of how admission processes were changed by introducing tools like that. So we will summarize all of those aspects and talk about them with nurses. And in the end, what we want to see, we want to see and we want to explore whether implementation of clinical decision support tools like PREVENT, so PREVENT specifically in this case, would decrease the rate of rehospitalization and emergency department visits from home care by identifying high-risk patients. So in terms of, you can find more details about this study in our recent publication that's in press, that's indicated here at the bottom of the slide. So I wanted to mention some emergent tools and give you a second example of a clinical decision support tool. So the assumption for this study, basically, is that we as nurses, we take care of a patient, right? And we do a lot of clinical documentation in the clinical notes and other types of electronic health record documentation, right? We have drop-down boxes. We have different types of things that we are supposed to record frequently about each one of our patients. Who reads nursing data though? Very few people, right? Maybe the nurse in the next shift will look at some of the nursing notes and maybe some of the data, but at a large scale, this data is not very useful, and people don't use healthcare providers don't use lots of nursing data in their mundane regular practice. So in a series of previous studies, a group from Columbia University and Harvard University found that nursing documentation patterns may predict patient deterioration and mortality. So in this specific study looked into the patients who are in the intensive care units. And what this study basically was trying to create is create a prediction of patient deterioration, so prediction of patient mortality risk when patients are admitted to intensive care units. What the study has found, that higher proportion of cardiac arrest patients had 5 or more comments, so nursing comments documented in 48 hours before arrest versus not cardiac arrest patients. So in this study, basically the study team showed that nursing comments were very informative for identifying patients at risk. Here are some other elements that were used in this study to predict patient risk for death and cardiac arrest. And you can see, for example, right, that some of the other biological variables, more of a biological censoring variables, like the respiratory rate, for example, or blood pressure or heart rate, were also somewhat associated with increased risk of death. However, some of the other factors that were almost stronger in terms of predicting patient death were comments on patient breathing, so saturation status, and comments on patient temperature. And why is that, right? Patients are not dying because nurses are documenting more comments in their clinical notes. And so what happens in this situation when we further understood the study results is that nurses' behavior is reflected in the electronic health records, right? So when nurses document more, so increasing number of documentation of temperature comments, for example, and saturation, so respiratory comments, is associated with worse patient outcomes because nurses are becoming worried. Nurses are becoming concerned about the patient. And they see in the actual world that patient is deteriorating. They would start providing more care, more frequent and higher levels of care to the patient. They would start documenting their concern in the electronic health records. And that's why these elements are predictive of patient deterioration. You might remember from the natural language processing description in this presentation that we did a study that similarly found that content of nursing documentation, so what nurses write about the patient, was associated with patient risk for hospitalization and ED visits from home care, right? So the idea that we had based on all of the studies is that we can use a system, so we kind of imagined the system that will proactively identify patients at risk and alert nurses on concerning patient trends. So basically, we use this idea to propose and get funded for a study that is called Home Care Concern, building risk models for preventable hospitalizations and emergency department visits in home care. This study was funded by the Agency for Healthcare Research and Quality. The objective of the study is to use cutting-edge data science approaches to improve timely identification of patients at risk in home care. So in terms of some of the methods for this study, so in aim 1, that you can see at the top of the screen, we basically want to further develop and validate a risk prediction model, home care concern. And how we are doing it, we are in the sub-aim 1.1, we're basically talking to clinicians, trying to understand risk factors. So this study has just started, so we are in the midst of aim 1.1. So speaking with clinicians, trying to understand what risk factors would put somebody at risk for hospitalization and emergency department visits during home care. We will then do a further natural language processing to identify those risk factors in the clinical notes. We will also extract those risk factors from any other types of data that we can identify. For example, we suspect that higher number of nursing visits to the patient will be a relatively strong predictor of negative outcomes, right? Because again, if nurses come to a specific patient more times, it will reflect their worry, their concern about the patient, and that's how we will extract the number of visits for a patient, number of nursing visits or number of physical therapy or other visits, and hope to use this as a predictor of patient risk for deterioration. We will then use several methods to develop predictive models for acute and chronic ambulatory sensitive care conditions to predict home care patient risk for preventable hospitalization and emergency department visit. In aim 2, we will pilot test this home care concern clinical decision support tool to identify patients at risk. So when you pilot test clinical decision support tools, you need to spend a lot of time working with nurses on mutual development of those clinical decision support tools. So clinical decision support tools should be well integrated into the clinical workflow, right? So they shouldn't be interruptive and annoying on one hand. On the other hand, they need to look good and they need to be useful for nurses. So that's what we will understand in the second aim of the study. In the last aim of the study, we will conduct a national survey in the United States to understand whether tools like that, like home care concerns, are reasonable in home care settings. And what would it take for home care agencies across the United States to implement tools, risk predictive tools like that into practice. So these were current trends in clinical decision support. So let's summarize. We thought about natural language processing and we learned a little bit about methods, how natural language processing is done. We then looked at several examples, including self-management status, prediction of ED and hospitalization, speech recognition. We then looked at several examples of higher level of integration. So how do you take this natural language processing to the next level, combine it with some other technologies, and create clinical decision support? One example was a study that's being conducted by my team called PREVENT, right? So it is a prioritization of patients coming out of the hospital to home care, where we identify high-risk patients and then recommend interventions to the nurses. And the last study that we looked at was home care concern, where we use artificial intelligence, natural language processing, and some other methods to identify patients who are failing during home care, and then creating some type of risk stratification, some type of risk alert for the nurses to prioritize those patients for care. So the reasonable take-home message after looking at those trends is that artificial intelligence can help to automatically extract important insights from nursing data to improve patient outcomes. And I hope that after this presentation, you'll know a lot more about using artificial intelligence like natural language processing or clinical decision support to improve patient outcomes. So I wanted to finish with this phrase: in God we trust, all others must bring nursing data.